Guess what the most common musculoskeletal injury is?
Ankle sprain.
Ankle sprain. That's what we're talking about today. I'm Dr. Paul Zalzal.
I'm Dr. Brad Waiting.
Dr. Danny Aurora, nice to be here. Thanks for having me, guys.
Oh man, we have a foot and ankle specialist here to give us the skinny on the ankle sprain. And stick around till the end to find out if you need surgery for your ankle sprain.
And it's controversial, you know, should you ice it? Should you immobilize it? Should you walk on it? We're going to talk about all that kind of stuff today. So let's start at the beginning. What are the structures that make up our ankle anatomically, Danny?
Yeah, so essentially the ankle is made up of three bones. You have the fibula, which is the outside bone in the lower leg with the tibia. They meet at the roof of the ankle and go on top of the talus bone, which forms that hinge joint. Those are the bony structures that form the ankle. And the ankle is well supported by a lot of ligamentous structures. So the ligaments are basically thickened bands that connect two bones. The major structures on the outside of the ankle, which is the lateral side, there are three major ligaments. There's the anterior talofibular ligament, and the calcaneofibular ligament, which is the CFL, and then there's the posterior talofibular ligament, which is the PTFL. That's all on the outside of the ankle, and then there's the major ligaments on the inside. There's a deep deltoid ligament and a superficial deltoid ligament.
Okay.
And the most common one to injure is?
The ATFL, or the anterior talofibular ligament. There's also a high ankle sprain complex that a lot of people talk about, and that's formed with the interosseous membrane, which is the ligamentous structure in between the two bones in the lower leg, and they meet down below, right above the ankle joint, and they form the anterior inferior tibiofibular ligament, and there's the posterior inferior tibiofibular ligament as well.
Okay, so it's high ankle sprain because it's higher,
It's
it's just above the
ankle joint, yes.
Okay. Factoid.
Yes.
15 to 30% of all musculoskeletal injuries that present to the doctor are ankle sprains.
Yes.
Factoid. 30%.
geez, where are you
30% of the injuries that go to a sports medicine doc are ankle sprain.
And the most common area is definitely the outside of that lateral ankle sprain where you roll over on your ankle. So let's talk about mechanisms. So how are people spraining their ankles?
So a lot of times they roll their ankles, and the common thing is, where does your foot go? So when I ask patients, how did you do it? A lot of times they say the foot went outwards, but they're actually meaning that the ankle's going outwards and the foot's going inwards, and that we call an inversion type sprain. There's also the position of the foot, which would also determine which ligament might be more prone to an injury or a stretch or a tear, essentially.
Okay.
Very commonly seen in many sports. Basketball, I think, is one of the most
A lot
common.
of the jumping ones for sure.
Right. Soccer, we see it a lot as well. And factoid, 25% more common if you have XX chromosomes versus XY chromosomes. For some reason, the women injure their ankle 25% more than the men.
Okay.
That is correct.
There you go.
Factoid, if you injure it once, there's a 70% chance that you're going to injure it again.
Okay.
These are big numbers.
You're full of facts, aren't you?
Tell
No,
me you're done with the
I'm now done. That was all the facts I knew.
Okay, so this has happened. What is the patient going to experience, Danny, when this happens? So how are they going to present, or what are they going to feel?
Yeah, so I think essentially when it first happens, a lot of patients have right away a lot of pain, depending on the outside or the inside of the ankle, or sometimes even both. There's subsequent swelling that happens pretty much right away if it's a really severe sprain. Sometimes they'll have difficulty putting weight on their foot. And then depends on what happens after that. And I think that's the key component is, where does the patient go? Okay. A lot of times people who roll their ankles, they say, oh, I'm just going to walk it off, and then they just go home. They do their classic icing and elevation, and they don't see a doctor or don't get it seen. Right. And then it continues to linger, and then becomes a bigger problem.
Right. So you think it's important to see someone relatively soon, depending on the severity?
It can, right? Because then you can get the diagnosis right away, and then you could get appropriately treated right away. And I think that's the big thing, is that a lot of times patients get treated very in a delayed fashion, and that could sometimes lead to more lingering effects.
Okay, so that's the history of what happened to you, and that's the symptoms you have. And now, just like Dr. Aurora said, you want to go see a doctor about our healthcare provider. And what is that healthcare provider, physician, going to look at when they examine your ankle? What are they looking for?
Yeah, so whether they present to an emergency department or go to a walk-in clinic, the biggest thing is a person able to put weight on it, bear weight. There are different areas of pain in the ankle. If there's some bony tenderness on the outside, which is pain on the bone, There's the rules that have been described in the literature in terms of why you should get an x-ray or not. The Ottawa ankle rules, people talk about that. So that's basically if you have pain on bone on the outside of the ankle, pain on bone on the inside of the ankle, an area of the foot where there's the fifth metatarsal, which is at the base of the baby toe, and also pain on the inside of that hind foot area of the foot. If so, then I think that's where an x-ray is always helpful, because that could rule out a more serious injury like a fracture, or even see if there's any displacement in the bones, particularly in the ankle.
Okay, so we'll link a video. We did a video about the Ottawa ankle rules. Our colleagues just down the highway to let you know when you think you should get an x-ray. So you're looking at it as a physician. So you did your areas of tenderness to palpation. You look at it, it's swollen, might be bruised depending on the timing.
Yeah.
Any other special tests you do to assess the stability acutely?
Yeah, so I think it's sometimes very difficult to get a good exam at the beginning, because if the ankle's really, really swollen, sometimes it's very difficult to appreciate, some displacement of the bone or whatnot. But definitely if there's bruising, swelling, pain on bone, those are the biggest findings initially. And then you could get into more ligamentous testing, where we're actually testing the ligaments. And I do that because I usually see them in a more dilated fashion.
Right.
And I think that's very important, because then you can determine, which ligament might be more lax, which means a little bit more loose, or if there's complete or gross instability where the ankle's really kind of rocking and has no stability because of the ligament injury.
Remember, the ligaments hold the bones together around a joint, and so if one is torn, there will be instability, and one bone will move in a way it's not supposed to move under another bone. That's what we mean by looking for instability.
And those ligament tests, like I said, I'm just shaking my hands like this, but essentially there's one test called the anterior drawer test that will test, that anterior ligament structure, the position of the foot. If you point the foot downwards in what we call plantar flexion, that really isolates that anterior talofibular ligament, or that ATFL. If you go into a more neutral or even dorsiflexion and do the same anterior drawer test, which is where you're pulling the heel and the foot by stabilizing the ankle forward, and if there's a lot more movement, you could also appreciate a calcaneofibular ligament injury as well.
Okay.
Okay, so that's it, guys. That's the history, what happened to you and what you're feeling. That's the physical exam, what the doctor is going to do when they're examining you. And then the special investigation. If you've watched our videos before, we always go history, physical exam, special investigations. In this case, the most common one would be an x-ray, if the physician is worried about bony fracture or something like that, or such ligamentous instability that the bones aren't lined up anymore. So that's your x-ray.
So most commonly for an x-ray, it's going to be normal. I guess sometimes you may see what's called an avulsion fracture, where the ligament, where it attaches to the bone, has pulled off a little flake of bone. Any other special tests?
Yeah, so there's other tests that we do, for investigations. Sometimes people come to me and they already have an ultrasound. I don't think, honestly, the ultrasound is the most effective initially. It'll say that there's an injury to a ligament, then they automatically get referred to a surgeon, thinking that they need surgery because they see the word tear potentially, which sometimes will be an overcall. An MRI could sometimes be very helpful, but more in that more chronic setting. But a lot of times the MRI could be very helpful to rule out a potential cartilage injury.
Right.
So sometimes if the symptoms kind of linger past that first few weeks and the patient's still having trouble putting weight on it, and there's no actual fracture seen on x-ray, the MRI could be helpful to investigate cartilage damage, which is also potential injury that can happen with an ankle sprain.
And this is what I think people don't appreciate. When you watch a slow motion video of someone spraining their ankles, particularly when they jump really high, that ankle gets into a very funky position. And when it does that, the ends of the two bones that are covered by cartilage when they make up a joint hit each other, and that shearing force can cause damage that you can't see on the x-ray. And this is
Correct.
what Dr. Aroras is talking about, but an MRI can appreciate that, and then either we can damage or even a piece can be knocked off that later on can become a problem.
However, majority of the time, acutely, the most investigation that's going to be done for the majority of ankle sprains is just an x-ray to make sure nothing
Sure.
bad's
Yeah, I
wrong.
think that's a good starting point, 100%.
Exactly. And then hopefully you get better, and then you don't need any of those other investigations or tests. But if you don't, then you might need some of the other stuff. So let's talk about it. We've done the history, the physical examination, the special investigations, and this is the part of the video where we get into treatment.
Okay.
So how do we treat ankle sprain? And we all treat so many of them because it's so common. Remember my factoid? How common it is?
We do
Very
remember,
common.
yeah.
Very
It's very common, so we all treat them. And even though we all treat them, it's still controversial in the literature. There's different ways to treat it. It's evolving, and not everybody treats them exactly the same way because it depends on a lot of factors: how severe it is, the age of the patient, how quick they're recovering. Generally, though, what is the mainstay of treatment of an ankle sprain?
Before we do that though, can we
Why?
grade them? Because because the way that we treat them is related to the severity of the injury. So
Yeah.
is there a way that we would agree conventionally on how to grade an ankle sprain?
Yeah, so I mean, there's the conventional way, grade 1, grade 2, grade 3. Unfortunately, they're not so precise. I mean, I think there's a little bit of variability. Some people might overcall or undercall, and it's not really the most specific way to do it. However, it's a good starting point. So there's a grade 1 sprain, which is where the ligaments are intact. You get a lot of inflammation. A grade 2 sprain where there's a partial stretch or a partial tear, and a grade 3 sprain, they talk about it being a complete tear where the whole ligament is completely ruptured.
Okay.
And most commonly, you're going to see grade 1, grade 2.
Grade 1, grade 2 sprains are probably the most common.
Okay.
And I think that's a good way to maybe just frame the injury. But a lot of times you really could determine the severity of an injury based on how long the symptoms are persisting or how long the patient cannot either potentially put weight on it. That could determine if it's a more serious sprain or not.
So almost after the fact where you're determining it.
Correct.
Okay, so as I was saying, how do we treat ankle sprains?
Yeah, so I think the first thing, I mean, if they present with lots of swelling and a hard time putting weight on it, getting them early immobilized is very important. Some people talk about getting into a cast right away or into a walking boot or an air cast they talk about. I think that's very important because it locks everything down. And then the second part of that is really get the swelling control. So there's controversy, heat, ice, all that. I think icing it in the acute because you have an initial inflammatory reaction is very important. Elevation. By elevating, you want to get the foot elevated above the heart. Yeah. Some people talk about them elevating, but their foot is really down, and then they come and they see you, and then their foot is completely swollen, bruised, and then they're like, "Oh, doc, I don't know what happened." So I think that's really important because once the swelling goes down, you can get the mobilization going. By that, I mean the range of motion, and it's very important to get the weight bearing right away if they could tolerate it, and also the range of motion going. And I think that will further accelerate their rehabilitation.
So I think this is a really good point because I think people with ankle sprains think that if they walk on it, they're going to do damage to it. So you're hearing from a surgeon say, listen, if we have it protected somehow, it is safe and actually good for your ankle to start loading it as soon as you can, once a fracture's been ruled out.
Yeah, and I'm very, I guess, aggressive in that sense. So when I see patients, I will put them in a walking boot right away. If they could tolerate, they could put full weight on it right away. And once the swelling's down, I will initiate range of motion. Yeah. And then the physio, if they could get it going within a week, I think that's very important. But again, that also is determined by how severe the sprain is, because sometimes you want to delay that if it's a more serious injury.
I think the other thing too that people always ask me, and when they're with me, I'm like, listen, you do not have to use crutches or a cane. If you feel safe in an air cast boot, I'll get them to do it because they don't believe that they can do it safely. Yeah. And say, look, now you're walking on it. So you don't need crutches. If you feel like you need to protect it at first, that's okay, but it is not mandatory to protect an ankle sprain.
Correct. And if they're having difficulty putting weight on it, I think that's where the crutch is important, right? Because we don't want people stumbling and using a boot and actually causing another injury because they're falling. So again, it is a bit of a case per case, and I know there's that causes a little confusion sometimes with primary care physicians or walk-in clinic doctors or even sometimes the emergency where it's not very clear. But it's not a bad thing to over-treat it by putting them in a mobilization device, whether it be a boot or a cast. But getting seen right away, I think, could be helpful, or at least getting their rehabilitation started early.
Okay, so this is basically phase 1 of treatment, okay? Rice, well, you've heard of rice before, rest, ice, elevation, doesn't mean put your foot in a bucket of rice. That's your cell phone if you get water in it. So rice, so that first part, the first phase, and the immobilization, and now I know what you're asking, you're thinking to yourself, well, how long do I have to wear this boot for? How long do I have to wear this splint for? And that is variable. It depends on how quick your swelling and pain go down. But generally, I know personally, I used to immobilize longer. Over the last year or so, since I've been reviewing the literature, and the newer literature is coming out saying shorter periods of immobilization. And the physios were on me. The physiotherapists are like, why are you putting them in a cast or boot for so long? So now for me, it's a boot for about 1 to 2 weeks for the majority of people. If it goes on and it's still hurting and it's still swollen, maybe longer. If it gets better really quick, maybe shorter than 2 weeks. But generally, about a week, maybe 2 weeks of that phase 1 where it's immobilized. And yes, you got to walk on it in that boot if you can. Put weight on it because that lines everything up. Yep. So anything else for phase 1 other than this rest, ice, elevation, boot? That's pretty well phase 1.
That's pretty much it at the beginning, right? And again, once the swelling, like I said before, once the swelling has subsided or is less, get the range of motion going. Okay. So it doesn't mean you're in the boot for 24 hours a day. It's you got to ice it, and you got to get the range of motion going right away.
And that gets us into phase 2, which is where you're going, this is going to be your new best friend. This is a TheraBand that when you go see a physical therapist or a physiotherapist, they're going to give you one of these and teach how to do a bunch of exercises with this. So what are the hallmark of phase 2, where you're at the physical therapist?
So I think that's where you're getting into more strengthening. Once the swelling comes down, you get the range of motion going, and then you're starting to get the muscles activated. And I think that's very important to actually prevent subsequent injury, because the muscles are basically what's going to guard your ankle. If you do get into that rolling position, you want your muscles to fire to protect it, to contract and stabilize the ankle before the ligaments get kind of stretched, which is that last line of defense. And then that's where you really want to work on strengthening, proprioception eventually. And there's different areas of how to do that. Obviously, the big thing is dynamic exercise for ankle rehabilitation. A lot of wobbly boards, those are good ways to really get the strength and really activate the muscles, which is the big thing.
Okay, and so you mentioned proprioception. So what is proprioception? Proprioception is your body's way of knowing where your limbs are in space. So if you close your eyes and you know your arm's extended, you know it's flexed, that's your proprioception telling you that. When you injure your ankle, you lose some of that proprioception in your ankle. And the problem is, if your body doesn't know where your foot is relative to your ankle, you can injure it again. So really working on proprioception is one of the things the physical therapist, the physiotherapist is going to do, just to teach your body to know where your foot is. Sounds silly, but that is a real hallmark of that phase 2 of treatment.
Yeah, 100%. And again, going back to that immobilization, you don't want to be immobilizing it too long, because essentially your muscles are on vacation for that long period of time. And then it's hard to recruit the muscles or ask them to start working again because they've been kind of shut down. And I do see that a lot. Patients come and say, the doctor put me in a boot for 6 weeks and then they haven't done anything. Yeah. And then it's really hard to play catch up then. And that's why patients are, how come my ankle's weak? How come I feel not confident in my ankle? It's still hurting. And that could lead into those things.
Is it possible to use the boot just for times when they're, say, you're going to be going on a longer walk or unstable ground, but like most of you are spending your time out of the boot, but keep it kind of as a reserve just for those, like, say, week 3 or week 4 kind of thing, but the majority of it is to start using those muscles to get back to normal?
100%. I think being selective, if it's winter, bad weather, you want to slap the boot on to be more protected. Doesn't mean you're taking a step back in your recovery. It's just you're being smart about it.
Okay, so that's phase 2, and then phase 3 now is really if you're like trying to get back into a sport or an athlete, and you're going to start some sports-specific type training.
Correct. To
get back in. If you're in a cutting sport, you're going to practice doing some cuts and things like that. And for the proprioception and the wall board and that, and one of the things that's done a lot is just standing on that one leg. And see, can you stand on that one leg for 30 seconds, the injured one? Can you stand on it with your eyes closed? To see if you have that proprioception and balance. But as you get into phase 3, which is more functional and sport-specific training, to get you back into that sport that you're doing.
And that in itself is a big topic. When are patients, athletes ready to return to sport? There's a lot of literature out there in terms of what's a good way to assess that. The big thing is, number one, are they able to stand on one leg, do those sport-specific type movements? Is their muscle of that injured leg up to about 70 to 80% of the contralateral side, the other side, which is their normal side to compare? And that's how we start to try to develop a program to see if they're ready to return to full go for their activities.
And that's the first question I get. I'd say 80% of the time, if I see a young athlete come in, how long am I going to be off for? Yeah. And we can't answer that on day 1 of presentation, because we don't know the severity, and everyone recovers differently. So really, that's going to be a decision made between you, your physician, and I'd say most importantly, your physical therapist or physiotherapist, because the things we look for are 100% of the range of motion. It can't be stiff if you're going to go back to your sport. 100% of the range of motion compared to the other side. And like you said, about 80 or 90% of the strength back in that ankle compared to the other side are the bare minimums you need to be able to get back into your sport.
Now, I would typically add minimal pain and also restored confidence. A big thing for athletes is if you're not confident when you play into it, that's when injuries rehappen a lot of times, because you can't trust that ankle. So the mental side's there as well. 2 questions that I'm going to get from my patients for sure. The older people, I'm going to go back to work. Is it bad if I stand on this sprained ankle for, say, an 8-hour shift as a cashier?
Yeah, so again, that's, patient-based, also symptom-based, right? If they're still having a lot of swelling and pain, that would be difficult to do a full day of work. And again, it's more of a case per case. But I think for the big thing is, if the symptoms are gone, they don't have any pain, and they've done their recovery.
Yep.
Doesn't mean you just waited 6 weeks and then that's it. But they've done their, their rehabilitation. The muscles are stronger. Then they could potentially gradually return to sport. Could be also return to work, right? So it's all, the goal is to get back to whatever activity they're trying to get to.
Okay, and now let's give you some numbers. Let's just take a guess, take a shot. What your experience is? How quick can that 14-year-old soccer player get back to playing soccer, or that 16-year-old basketball player get back to basketball? Roughly, I know it's a range, a ballpark range.
So again, it's very case by case. So these are not hard rules. And let's just say everyone has done what they should have done initially.
Yes.
So in a grade 1 sprain, some people talk about 2 to 3 weeks you could technically get back. In a grade 2 sprain, it could be anywhere between 4 to 6 weeks. And those really severely, badly sprains, or even the high ankle sprain, which is a complete other topic, could be even sometimes longer than that 6 weeks. Could be even up to 8 weeks, even up to 3 months, in some bad ankle injuries.
Okay, yeah, and those my numbers we would match that. I'd say like in a very mild one, 2 weeks. You could be back 2 to 3 weeks. If it's more severe, it could take up to 3 to 6 weeks. And then those high ankle sprains, like you said, that's a different story. We should do a whole separate video on those. You can lose a whole season with a high ankle sprain.
You can, and that's where sometimes the surgery comes into play, and that'll potentially delay the return.
Okay. And the other thing I want to know is how do you feel about a brace going back to, when you go back to sport, how do you feel about a brace?
Yeah, so again, depending on the type of sport or activity they're trying to get back to, I think it does lead to confidence as well, right? Wearing a brace can be helpful to allow them to get back. It'll give them that confidence. It'll also protect the ankle. There's also the flip side of that is always wearing the brace could technically weaken the ankle because people use that as a crutch. But there's certain sports where patients or athletes will be wearing the brace no matter what. Like basketball, you see it a lot.
Volleyball middle.
Volleyball,
Yeah,
100% as
sure.
well. So there's sport-specific things that might require that added stability, or sometimes even the taping. Football players always get the tape plus the spat on top of their shoes. So because they're really prone and it's a high velocity, high energy and type activity.
Yeah, if you're going to get taping, you have to get it done by someone who really knows what they're doing for it to have an effect. But I agree with the bracing after. And one thing that I came across in literature was the length of bracing. How long are you going to brace after your sprain in your sport? That's variable. And it could be up to a year. I mean, I read some papers that said, from the biology of the thing, you might have to wear that brace for up to a year. But definitely, I think, consider you're going to be wearing that brace when you go back to your sport for several weeks, if not months.
Okay, so you've done all that stuff. You're someone now who's sprained their ankle 6 times. You have chronic pain, you have instability, you can't play your sport. Is there any role for surgery for these types of problems?
Yeah, so I think that's where the surgery comes in. In an acute setting, very rare that we'll do or offer an operation.
Okay.
Again, the times we would do that is if there is a secondary injury, like a cartilage injury with a displaced, meaning a flipped fragment or something like that in the ankle, that would be something that we would probably tend to more acutely. But if just for ankle sprains as a whole, acutely, you probably wouldn't be doing an operation. If there's recurrent instability, that means constant rolling the ankle, repetitive injuries, that kind of thing, where the athlete or patient doesn't feel confident on the ankle, they keep rolling it, and they're just kind of in that vicious circle. There's a role for potential surgery, provided that the ligaments are seen to be torn, whether it be clinically, it's unstable on exam, or whether with an MRI or additional imaging that you would be able to determine if there's an actual injury, then I think there's a role for surgery.
Okay, so surgery, bottom line is the vast majority of the time, your acute ankle sprain is going to be treated without surgery. And then surgery, more often than not, if it's going to happen for your ankle sprain, is going to be down the road when you develop if you develop some chronic instability. Now, there are some weird and wacky sprains, I guess, like a Maisonneuve type injury, or such a severe sprain that your ankle is actually dislocated without any broken bones. That may need surgical intervention.
And that's where we didn't talk too much about. That's that high ankle or syndesmotic, or where you injure the syndesmosis, which is that complex above the ankle. That's a different ankle sprain in itself. That's a very unstable type ankle injury, and a lot of times, depending on patient factors, goals in terms of whether it's an athlete or whatnot, we might be prone to doing surgery in a more acute fashion.
Okay, and those are rare. That's not the bread and butter of ankle sprains that you get. That might even be a whole separate video.
Yeah, we could probably do a whole other topic next
100%.
Boy, that's a pretty exhaustive.
A lot. Plus all your factoids today.
I had some factoids I had to share.
My ankle's hurting from all those
Yeah.
facts.
I mean, and so that was the question. The main question is, will I need surgery for this? Really, no. Acutely, the vast majority of the time, no. When can I get back to my sports? Very variable. We've seen it as low as like a couple of weeks to take a couple of months or more, depending on the severity. And how long do I have to wear that boot or that cast? Again, that depends too, but it's going to be pretty short relatively because we want you to start moving it when I start walking on it and get weight bearing right away.
But the take-home message is, if this happened to you, get seen. Get seen so you get appropriate treatment started quickly to reduce your possibility of having a recurrent injury. And if this has happened to you, please leave a comment. Let us know what happened to you, what you had, how it's going. And if you like this video, please like it. Subscribe to our channel.
And remember, you are in charge of your own health. Dr. Aurora, thank you so much. That
Thank
was
you.
awesome.
Thanks for having me, guys.
Awesome. We'll see you next time.